I'm the clinical nurse specialist here at LAMC. Today I'll be discussing hospital-acquired infection prevention measures. Hospital-acquired infections continue to be a global problem in healthcare in our medical center. The most common cause of hospital-acquired infections is through healthcare workers, mainly from failure to comply with the recommended infection control guidelines. In the next coming slides, I will be discussing strategies to prevent healthcare-associated infections. The objectives for this presentation are define basic principles of CLABSI and CAUTI prevention, review evidence-based clinical practices shown to reduce hospital-acquired infections, and review medical center policies and procedures to standardize nursing practices across the organization and to ensure that every patient receives the same level of care. At LAMC, we have an infection prevention team that partners with our infectious disease physicians and other key stakeholders to promote continuous quality improvement through infection prevention, surveillance, and performance improvement activities and interventions. One of the many ways we help reduce our hospital-acquired infections here at LMC is by surveillance via this patient rounding tool. Every unit should have a dedicated day with nursing leadership rounds with their infection prevention nurse. This tool helps capture data so nursing leadership can identify gaps in practice or trends to improve our quality and care that we give to our patients. Other areas of surveillance are CAUTI, CLABSI, skin rounds, TREPI bundle, and C. diff. The rounds are twofold. We have environmental rounds where nursing leadership and IPRNs observe the clinical environment. For example, if the team is rounding for CAUTI, then the expectation is that the indwelling catheter is not touching the floor. There is a green sticker. The catheter tubing is clean, free of any incrustation, free from any dependent loops, and anchored to the patient's leg. In addition to environmental rounds, the team also may answer any questions or provide patient and family education. The second portion of the rounds include chart auditing that is done by both nursing leadership and IPRN. These are the different components that we capture during our rounds for documentation and observation. In the next coming slides, I'm going to discuss central line associated bloodstream infections. In the acute care setting, there are clinical conditions that warrant a central line placement. Central line placements have associated risks that increase a patient's morbidity, mortality, and hospital stay. Nursing bundles are a structured way of improving the process of care and patient outcomes. The CLABSI bundle is a set of evidence-based practices that, when implemented together, have been shown to produce better outcomes and have a greater impact than the implementation of individual measures. In addition, nursing bundles also help create reliable, and consistent care. The central line maintenance bundle includes hand hygiene, aseptic technique when accessing and changing needleless connectors, standardizing IV tubing change and dressing changes, daily CHG bath, and daily review of catheter necessity. You can always reference your local med center policy, CVC Care and Maintenance Policy number 3038. And you also have lifted cup procedures, which provides best practice and evidence-based guidelines on procedures and patient care. You can access them both through your Inside LAMC homepage. The 5 moments of hand hygiene is an evidence-based approach to prevent hospital-acquired infections. The 5 moments include before touching the patient, before performing any clean aseptic procedure, after exposure to bodily fluids, or after procedure that increases your risk to exposure of bodily fluids, and after the patient and or touching the patient's surroundings. I want you to reflect back in your own practice and think about if you really follow these 5 moments of hand hygiene. Several studies have indicated that healthcare providers clean their hands less than half of the time they should. Practicing good hand hygiene is the simplest and most effective way to prevent hospital infections. I also want to stress the importance of disinfecting those high touch point areas in your environment. CHG bath is an important component of our CLABSI, and CAUTI maintenance bundle. The literature shows that incorporating daily CHG baths to patients with central lines have reduced central line associated bloodstream infections by 40%. According to our KP South region, CHG is classified as a medication, which is one of the reasons why it has been added to the MAR. Our medical center policy indicates that it is the RN's responsibility to assess allergies and any possible contraindications before delegating this task to the nursing assistant. A total of 6 cloths shall be used for any adult weighing greater than 66 pounds. Please remember that CHG cloths should not be used on areas with skin breakdown, open wounds, incisions, or the genital area. Make sure to use a circular or back and forth motion with light friction. Colonization of needleless collectors is considered the cause of 50% of post-insertion catheter-related infections. Breaks in accepted technique from failure to disinfect result in contamination and subsequent biofilm formation within the needleless connectors and catheters, thus increasing the potential for infection for central and peripheral catheters. Cural's disinfecting port protectors are alcohol impregnated caps, which provide passive disinfection of the IV access point in 1 minute. The alcohol provides a physical barrier of contamination between accesses for up to 7 days. Please remember the Cural's caps are a single use only. How the needleness connector is disinfected before its access will determine how many organisms will enter into the bloodstream and how quickly biofilm will form. For that reason, our policy requires that RN scrub the hub after removing an old Cural's cap. Please make sure you apply adequate friction when scrubbing the hub, like juicing an orange. It's the friction that aids in properly disinfecting the needleless connector. Needleless connectors carry significant risks of bloodstream infections. Thus, evidence-based practice support that changing the needleless connector under the following clinical scenarios reduce the rates of clinical line associated bloodstream infection. It is the RN's responsibility to change the needleless connector prior to drawing blood cultures from this catheter, which eliminates the risk of false positive cases. New guidelines also support changing needleless connectors when the primary administration set is changed, which is every 96 hours. The following reasons are indications when the nurse is responsible for changing a needleless connector. You can find this and reference your policy for your med center. The following are recommended best practices for changing IV tubing to reduce the risk for infection. This section of the maintenance bundle is a known area for improvement for all departments. The frequency of IV tube change is dependent upon the type of medication that is running and whether the IV tubing is running continuously or if there's an intermittent disconnection of the primary line. If you come on your shift and find that your IV tubing is not labeled properly and you cannot identify the last time it were changed, it is best practice to replace all your tubing and add a new label. This practice assures that the IV tubing interval change does not go beyond the recommended time. We are all prone to human error, and because of that, we must create an environment that minimizes human error as much as possible. Again, you can reference when to change your tubing in your med center policy. For primary second lines that are continuous, they're every 96 hours. Anytime you're disconnecting a line from the primary line, it's every 24 hours. Lipids are every 12. TPN with lipids is every 24 hours. TPN without lipid every 72. And anytime blood components are used, it's only 4 hours. A complete dressing assessment should include the following: correct biopatch placement with the printed side up and edges approximated around the catheter tubing, date and initials of the RN, needleless connectors should have Cural caps in place, and the dressing should be clean, dry, and intact. During environmental rounds, we often find missing Cural caps, incorrect placement of biopatches, and oftentimes dressings with a little bit of drainage. Those are all areas for improvement in our clinical practice. Don't forget to take credit for your education. Your education can include any component of the CLABSI maintenance bundle. Our goal is zero HAIs, so early removal should always be part of your plan of care. Use Secure Chat to connect with the primary physician about the plan of care and early removal. If you know your patient is planned to go home with a central line, your education should include infection prevention. In the next coming slides, I'm going to discuss nursing practices related to the CAUTI prevention bundle. CAUTI is an infection of the urinary tract caused by placement of an indwelling catheter. The criteria for CAUTI diagnosis includes clinical symptoms such as fever, pelvic pain, and positive urine culture. This criteria applies to any patient with a current indwelling catheter or a patient who has had an indwelling catheter removed within the past 48 hours. CAUTIs are the most healthcare related associated infection worldwide, resulting in increased costs, hospital stays, and substantial patient morbidity. The CAUTI Prevention Maintenance Bundle is a collection of evidence-based interventions for patients with indwelling catheters that, when implemented together, result in better outcomes than when they're implemented individually. A recent large study in the United States demonstrated the following interventions aided in the reduction of catheter use and CAUTI rates in non-ICU acute areas. The three components include avoiding the use of urinary catheters altogether by considering alternative methods for urine connection. Alternative methods include condom catheters, intermittent catheterization, and PureWick. Using aseptic technique for Foley insertion and following proper maintenance bundles after insertion. The third component is daily assessment of the presence and need of indwelling catheters. Appropriate indications for urinary catheters include urinary retention, close monitoring for urine output in unstable patients, and to assist with wound healing. Again, this is a reminder that you can always reference your medical center colic prevention policy number 6313 and Lipton-Cott procedures to support and guide your nursing practice. As previously mentioned, appropriate hand hygiene prevents up to 50% of avoidable infections acquired during healthcare delivery, including those affecting healthcare workers. The following diagram illustrates the correct technique of hand washing. The hand washing steps include palm to palm, back of the hands, in between fingers, thumbs, fingernails, and wrists. This is the correct way you should all be washing your hands. And remember, the total time of hand washing should be 20 seconds or the equivalent of singing the happy birthday song. All patients with indwelling catheters shall have a leg securement device in place. The securement device helps prevent trauma from pooling and added friction of the catheter in the urethra. During environmental rounds, nursing leadership and the IPRN also assess for evidence of seal tampering. A missing seal provides a clear indication that the closed system has been compromised. Open systems create the risk for bacterial entrance into the urinary tract. Maintaining the bag below the level of the bladder supports emptying of the bladder. The urine bag should not be touching the floor, and the green sticker that is placed on the urine bag serves as the purpose of reminding other disciplines, patients, and their family members the importance of keeping the bag off the floor. The bag should also be free of any kinks or dependent loops. Dependent loops can cause urine to accumulate and has been known to cause bacteria, thus increasing the risk for urinary tract infections. All of these nursing interventions are mentioned in the policy and procedures of the medical center-wide policy, CAUTI prevention. Every day that the indwelling catheter stays in place increases the patient's risk of acquiring a UTI. The risk of UTI increases to 30% after only 4 days in. Daily CH baths and pericare after BMs help reduce the associated risk for UTI. CHG baths should also include wiping down the catheter tubing, and exit port. All patients with indwelling catheters should have an order for daily CH bath. During rounds, it is common to find Foley bags to be greater than 50% full. When patients go by transport, what is the first thing the transport would do? They place the Foley bag on the bed. Or when patients are ambulating with PT or sitting on a chair, oftentimes the urinary bag sits or is raised above the bladder. All these practices increase the patient's risk for acquiring a urinary tract infection. Thus, please remember to regularly empty your urinary bags and to empty the bag prior to patient transport, physical therapy, or sitting up on a chair. The drainage bag should not be greater than 50% full to prevent traction on the urethra from the weight of the urine bag and to also maintain positive urine flow and prevent reflux of the urine. The goal is to always have a closed system, meaning there is no removal or tampering of the catheter seal. Look for the green or red seal depending on the Foley catheter brand. Routine irrigation of the indwelling catheter is not recommended by CDC guidelines. However, obstructions sometimes occur and require disconnection of the port to manually irrigate the bladder to remove blood clots causing outlet obstruction. Signs and symptoms of potential catheter obstruction include absence of urine flow from the catheter, urine flow bypassing around the catheter, meaning leaking around the catheter, and suprapubic pain that becomes more pronounced as the bladder fills. Before initiating catheter irrigation, a bladder scanner can be used to confirm whether a decreasing urine output is due to a blockage or reduced urine in the bladder, thereby decreasing the number of unnecessary irrigations and minimizing the break in closed drainage system. If an indwelling catheter is known to be obstructed by sediment, not blood clots, it is best practice to change out the entire system. In the event manual bladder irrigation is medically necessary, a new piston syringe shall be utilized every time. To have better control of your environment, it is best to discard the material after each use instead of leaving it at the bedside. These are the results from a gap analysis survey that was posted earlier this year. Thank you for those who participated in the survey. The results of the survey demonstrated there are gaps in both nursing knowledge and practice. Learnings from the survey demonstrated that not all staff use a new sterile piston with each manual irrigation. Uh, In addition, not all staff clean the drainage port for 30 seconds prior to removal. And lastly, not all staff wipe down the bedside table prior to setting up their supplies for the procedure. These gaps in nursing practice and knowledge further increase the risk for patients acquiring a urinary tract infection, as the procedure alone is already high risk. If your patient's medical condition requires manual irrigation, assure that the physician places the correct order with clear nursing instructions. The RN will initially insert 120 mLs of sterile NS and aspirate or pull back 60 mLs. The reason for leaving 60 mLs in the bladder is to help prevent the tip of the catheter from sticking against the bladder wall. If the tip of the catheter gets stuck to the wall of the bladder, then it can act as a plug, preventing fluid from draining from the bladder and may cause minor irritation or discomfort. We will go over this skill in your PPU. This is an example of proper documentation for manual bladder irrigation. Please make sure you identify the correct action. Correctly assess the urine characteristics by notating if there was blood clots. The fluid type, how much fluid was infused, and the total volume output. The necessity of indwelling catheters shall be assessed daily. It is a shared physician and nurse responsibility. This information shall be included in the nurse handoff communication during NK report. Have a conversation with the primary physician during rounds or use the secure chat function. Many of you are aware that we had a shortage on indwelling catheter kits being stocked with sterile povidone iodine swab sticks. Our current stock of povidone swab sticks have been identified to not have sterile solution. This supply shortage temporarily increased our CAUTI rates across the organization, even in areas where it is very uncommon to have CAUTIs. For this reason, the IP team has asked the education team to create an alternative process that will not break sterile technique. Some initial workarounds to this process was for another nurse to open the iodine for the primary nurse. This practice is not recommended because there is a break in aseptic technique due to the fact that the solution itself is not sterile, thus resorting to a 2RN insertion process. Lastly, I wanted to discuss the process of proper urine collection. The infection prevention team has identified that there are some inconsistencies in urine collection practices. I want to emphasize the great importance of proper urine collection by using preserving urine in boric acid helps eliminate bacterial overgrowth of normal flora, leading to more accurate results. Please remember to send urine samples in tubes with preservatives who have preservatives of boric acid, as urine has been known to start to colonize after sitting in a collection tube greater than 2 hours. Reflex urine cultures are not recommended. Cultures shall be ordered based on clinical signs and symptoms of UTI. Patients with indwelling catheters should have at least one of the following clinical signs and symptoms to warrant an order for urine culture. One of the three symptoms, one of the following symptoms include fever greater than 38 degrees Celsius, suprapubic tenderness, pelvic pain, or tenderness. Routine changing of indwelling catheters or drainage bags is not recommended, nor it is supported by research. Changing catheters and drainage bags shall be based on clinical indications such as infection, obstructions, or when the closed system is compromised. But it's old. I think it works. We have one. starts at 12, right?